Honorable chairpersons, respected panelists, learned audience, Assalamu alaikum. My today's topic is Ortner syndrome due to cardiac myxoma, an uncommon presentation of a common problem. A 36-year-old lady sought medical consultation for 8-week history of effort intolerance and exertional dyspnea 11 months ago. She had been treated as bronchial asthma by local physicians. Her physical condition was not improved. Rather, she developed dizziness on exertion. She consulted a cardiologist locally and was referred to NICVD for further management. She was admitted at coronary care unit of NICVD. She was hemodynamically stable at CCU of NICVD with a regular pulse of 96 per minute. Blood pressure was 90 by 60 millimeter mercury. First heart sound was normal and second heart sound was loud. And there was a mid-diastolic murmur in mitral area, which had a changing intensity with change of posture. This was her ECG, which showed right axis deviation. Then we have done echocardiography, and echocardiography revealed we found a mass which is occupying the left atrium, that is homogeneous, inhomogeneous mass, which is prolapsing towards the left ventricle during diastole. This is the M mode through the mass, where it showed L is slightly dilated, which is about 45 millimeter. LV function and LV dimension seems to be normal. This is the typical 4-chamber view showing there is a mass which is attached with this peduncle with the intra-atrial septum and prolapsing towards the left ventricle during diastole. This is 2-chamber view showing that mass and which is attached with the peduncle with the intra-atrial septum. This is the apical 3-chamber view. And obstruction, mitral valve obstruction is about 30 millimeter peak, and the mean was 23 millimeter mercury. And patient also have severe pulmonary hypertension, which is about 92 plus right atrial pressure. Her RV function was normal, and inferior vena cava was not dilated and less than 50% collapsibility. We urgently seek surgical consultation for possible excision myxoma, but operation could not be done because of outbreak of COVID-19. And that time, our operation theater were closed. In the meantime, patient developed intractable cough and hoarseness of voice. We detailed survey the respiratory and neurological system, but we revealed normal findings. A series of investigations were done, but most of the test report appeared unyielding, including CT chest, but laryngoscope showed there is left vocal cord paralysis. At the time, surgeon had COVID-19, so operation was deferred repeatedly. In that time, one question was on our mind, that is it was Ortner syndrome caused by severe pulmonary hypertension or dilated left atrium? At last, operation was done. At 8 centimeter pedunculated tumor arose from the fossa ovalis in the left atrium. Surgeon removes the tumor and repaired the small resulting defect in the atrial septum. The gross and microscopic pathology of the tumor confirmed an atrial myxoma. Atrial dysrhythmias complicated the patient's post-operative course, however, resolved prior to discharge. Subsequent follow-up after 3 months revealed she had considerable improvement regarding her voice and cardiac symptoms. Her voice is almost completely restored. Follow-up laryngoscopic examination showed improved abduction of the left vocal cord during phonation, suggesting resolution of the recurrent laryngeal lung palsy. Ortner syndrome was first described by Robert Ortner, an Austrian physician, in 1897 in 3 cases of mitral stenosis with dilated left atrium. Subsequently, different cardiovascular causes like mixed mitral valve disease, pulmonary hypertension, cord pulmonary, aortic aneurysm, Eisenmenger syndrome were added to the etiology. Hence, the term changed to cardiovocal syndrome. just after one century after the first demonstration of Ortner syndrome in 1989, Professor Rubens reported the first case of Ortner syndrome due to Myxoma. Pulmonary hypertension or some cause leading to dilatation and increased tension of the pulmonary artery may be responsible for vocal cord palsy. Vocal cord paralysis occurs due to compression, stretching, and pulling of the left recurrent laryngeal nerve. It would therefore be pertinent to look beyond the larynx for a cause of vocal cord palsy in patients presenting with hoarseness of voice. Treatment is directed towards the correction of underlying etiology, and prognosis depends on the underlying etiology as well as the duration of the illness. I'm showing my heartfelt gratitude to my teacher, Dr. A.K. Monarul Islam, who is working as an associate professor of cardiology in NICVT for this case. Thank you all for giving me attention.
Thank you, madam, for excellent presentation. Is there any question from the audience to the presenter? If no question from the audience, we will proceed to the next case. Okay, sorry.
স্যার এই পেশেন্টটা আসলে হচ্ছে কি ডায়াগনোসিস বাই এক্সক্লুশন, যেহেতু আমরা ওর ভয়েসের অন্য কোনো কজ পাই নাই, রেসপিরেটরি কজ পাই নাই স্যার, আমরা নিউরোলজিক্যাল কজ পাই না, এবং পেশেন্টটাকে একদম ল্যারিঙ্গোস্কোপিতে ডেফিনিট ভোকাল কর্ড প্যারালাইসিস পাওয়া গিয়েছে, এবং সেটা আফটার অপারেশন পেশেন্ট হচ্ছে সাবসাইডেড হয়েছে, পেশেন্ট ইমপ্রুভ করেছে, সেক্ষেত্রে আমরা মানে ইট ইজ দ্য ডায়াগনোসিস অফ এক্সক্লুশন স্যার, টোটাল রিকভারমেন্ট হয়েছে স্যার। No, sir, it's single entity. Now, Myxoma mainly pulmonary severe pulmonary hypertension এর জন্য আমরা ভাবতেছি, কারণ এখানে এল এ যে ডায়ামিটারটা, সেই এল এ ডায়ামিটার অত বড় না যেটা হচ্ছে কম্প্রেস করতে পারে। এখানে সিভিয়ার পালমোনারি হাইপারটেনশন, হাইপার pressure over the left laryngeal nerve may be culprit for this lesion. Here we think so or thought so. Pressure of sir pulmonary artery pressure. Pulmonary is severe pulmonary hypertension, nearly 102 millimeter mercury for this patient. Yes, sir, yes. There's literature survey showed a few patients who presented Ortner syndrome due to dilated pulmonary artery due to pulmonary hypertension. Maybe, sir. Not, sir. Yes, sir. Most likely, sir.
Thank you, madam, for your excellent presentation.